The day the auditors landed, a survival story, and the unlikely birth of JCI. Welcome to the panic room. Picture this. You're halfway through your morning shift. The coffee is lukewarm, the EMR is freezing again, and someone just paged you about a patient who insists their gallbladder pain is definitely related to the full moon. You're managing. You're surviving. Then, from somewhere down the corridor, you hear it, a voice that shouldn't be that loud in a hospital. The JCI auditors are here. Suddenly, the entire floor transforms into a dystopian movie set. Nurses are speed walking, never run in a hospital, remember? With clipboards they swear they've been using all of year. Biomedical engineers are frantically checking if that defibrillator actually has a maintenance sticker or if someone just drew one with a Sharpie last night. The medical director develops a nervous tic. Someone in administration starts praying in 3 languages. And you? You're mentally reviewing whether you documented that last hand hygiene moment because apparently the fate of the institution now rests on whether you used foam or gel. Welcome to the love-hate relationship healthcare professionals have with the Joint Commission International. It's the organizational equivalent of your mother-in-law visiting. You know her standards are probably good for you. The house has never been cleaner, but dear God, the stress. But here's the thing. Nobody tells you during that panic spiral. JCI didn't start as a bureaucratic monster designed to ruin your Tuesday. It started with one doctor who had the audacity to suggest that maybe, just maybe, we should check if our patients actually survive our treatments. Wild concept, right? Let me take you back to 1910, when medicine was basically the Wild West with stethoscopes. The origin, Dr. Codman, or the guy everyone ignored until they didn't. Meet Dr. Ernest Codman, a Boston surgeon who, in 1910, committed the cardinal sin of medicine. He asked uncomfortable questions. While his colleagues were perfectly content performing surgeries, collecting fees and moving on with their lives, much like ghosting but with anesthesia, Codman had this annoying habit of following up on his patients. He wanted to know, did they get better? Did they die? Did the surgery help? Or did we just give them a really expensive nap and a scar? He called this revolutionary idea the end result system. The concept was simple. Track patient outcomes, learn from mistakes, and, brace yourself, admit when you screwed up. His colleagues reacted exactly how you'd expect. They hated him. Codman presented his findings at the Philadelphia County Medical Society in 1915, complete with detailed charts showing his own surgical failures. The medical establishment responded with the professional equivalent of, "Sir, this is a Wendy's." They rejected his ideas, mocked him publicly, and essentially turned him into the Cassandra of surgery, prophetic, accurate, and completely ignored. But Codman was stubborn, a trait that would later define every quality improvement officer ever. He kept pushing his end result idea, even creating his own hospital to prove it could work. Spoiler alert, it did work. He tracked outcomes, identified complications, and actually improved his surgical success rate. Unfortunately, being right doesn't always make you popular. Codman's hospital eventually closed due to financial problems. Turns out transparency doesn't pay the bills. And he spent his later years somewhat bitter, convinced the medical world would never embrace his vision. Plot twist. They totally did. Just, after he died, and that's sad, or maybe it isn't. The birth. From Boston Rebellion to global empire. Fast forward to 1951, post-war. America is booming. Hospitals are multiplying like rabbits, and the medical field is finally starting to think, maybe we should have some standards. The American College of Surgeons, who had been dabbling in hospital standardization since 1918, inspired partly by Codman's work irony, teamed up with other medical organizations to create the Joint Commission on Accreditation of Hospitals, JCAH. The goal? To establish minimum standards for hospital operations and patient care. Translation: let's make sure hospitals aren't operating like 19th century sawmills. For decades, The Joint Commission focused on the United States, gradually expanding its standards and becoming increasingly sophisticated. Read, more paperwork. They developed comprehensive evaluation criteria, on-site surveys, and the now infamous accreditation process that makes grown administrators weep. But then came the 1990s, the era of globalization, dial-up internet, and the radical idea that maybe healthcare quality shouldn't stop at national borders. Hospitals in Singapore, Dubai, and Sao Paulo were performing complex surgeries. International patients were traveling for medical care, and a crucial question emerged. How do you prove your hospital isn't going to accidentally kill someone when they don't speak your language and their insurance company is 8,000 miles away? Enter Joint Commission International, JCI, officially launched in 1998 as the global arm of the Joint Commission. The founding logic was beautifully simple. Take the standards that worked in American hospitals and adapt them for a global audience. Create a universal language of patient safety. Build a system where a hospital in Bangkok could demonstrate the same commitment to quality as one in Baltimore. And thus, JCI was born, not as a villain, but as an ambitious attempt to export the best of American healthcare quality standards while, theoretically, leaving behind the worst parts of American healthcare. The billing nightmares stayed domestic, thank God. The Gold Seal, how a logo became healthcare's Oscar. Here's where things get interesting. And by interesting, I mean financially motivated. JCI's Gold Seal of approval quickly became the Michelin star of hospitals. Not because healthcare administrators suddenly became obsessed with quality, though many genuinely cared, but because medical tourism exploded in the 2000s. Let's paint the picture. An American patient needs a hip replacement. In the US, this costs $40,000 and comes with a side of financial ruin. In Thailand, the same procedure costs $15,000, includes a hospital room that looks like a 5-star hotel, and leaves enough budget for a beach vacation afterward. But there's a catch. How do you trust a hospital in a country where you can't even read the exit signs? Answer: look for the Gold Seal. JCI accreditation became the universal shorthand for this hospital probably won't kill you. It told patients, yes, we follow international safety protocols. Yes, our surgeons are qualified. No, we won't reuse your IV catheter. Suddenly, hospitals from Dubai to Delhi were scrambling to get JCI certified, not just for altruistic reasons, but because it was a competitive advantage. The Gold Seal meant access to wealthy international patients, partnerships with global insurance companies, and the ability to charge premium rates. JCI had effectively gamified hospital quality. And honestly, it worked. By the 2010 years, JCI had accredited over 1,000 organizations across 100+ countries. The Gold Seal became so prestigious that even hospitals serving primarily local populations sought certification for the credibility and operational improvements it brought. But here's the kicker. While the marketing value of JCI is undeniable, the operational value is actually profound if you can survive the preparation process without developing a stress disorder. The standards, aka the commandments for not messing things up. Let's address the elephant in the room. Why is JCI so obsessed with seemingly ridiculous details? Why do they care if your crash cart has a checklist? Why must every medication be double-checked like you're launching nuclear codes? Why is hand hygiene treated with the solemnity of a religious ritual? Because patients die from preventable mistakes constantly, globally, in terrifying numbers. The World Health Organization estimates that millions of patients worldwide suffer harm due to unsafe healthcare every year. Medication errors, surgical mistakes, hospital-acquired infections, these aren't abstract statistics. They're human beings who trusted the healthcare system and got hurt because someone skipped a step. This is where JCI's International Patient Safety Goals, IPSG, come in. The 6 commandments of please don't kill anyone today. Let me break them down in terms that won't put you to sleep. IPSG 1. Identify patients correctly. Translation. Make sure you're operating on the right person, not their roommate. This seems obvious until you realize how many patients share names, how chaotic emergency departments are, and how easy it is to grab the wrong chart. JCI demands at least 2 patient identifiers, name, date of birth, for example, before any procedure. Is it annoying? Yes. Is it necessary? Absolutely. IPSG 2 improve effective communication. Translation: actually talk to each other like functional adults. Healthcare miscommunication kills people. Orders get misheard, critical results go unreported, and handoffs turn into a game of telephone with someone's life on the line. JCI requires standardized communication protocols, like readbacks for verbal orders and structured handoffs. Basically, they're forcing healthcare teams to communicate like pilots, clearly, precisely, and with confirmation. IPSG 3. Improve the safety of high alert medications. Translation: don't accidentally give someone enough potassium to stop an elephant's heart. Certain medications, insulin, anticoagulants, concentrated electrolytes, are unforgiving. 1 decimal point error, and you've got a disaster. JCI mandates special protocols for storing, labeling, and administering these drugs. It's the medical equivalent of putting a lock on the nuclear button. IPSG 4. Ensure correct site, correct procedure, correct patient surgery. Translation: remove the appendix, not the kidney, and make sure it's their appendix. This goal gave birth to the surgical timeout, that moment before incision when everyone stops and confirms they're doing the right surgery on the right patient at the right site. Yes, the patient's name gets repeated multiple times. Yes, the surgeon physically marks the surgical site, because the alternative is operating on the wrong leg, which happens more often than anyone wants to admit. IPSG 5. Reduce the risk of healthcare-associated infections. Translation: wash your damn hands. Hospital infections are a global nightmare. Patients come in with one problem and leave with MRSA as a parting gift. JCI obsesses over hand hygiene because it's the single most effective way to prevent infection transmission. The WHO's 5 Moments for Hand Hygiene framework is drilled into every JCI accredited facility until staff can recite it in their sleep. IPSG 6. Reduce the risk of patient harm from falls. Translation: stop letting grandma hit the floor. Falls are the most common adverse event in hospitals, especially for elderly patients. JCI requires systematic fall risk assessment and prevention strategies. Yes, this means more documentation, but it also means fewer hip fractures from preventable falls. These goals aren't arbitrary bureaucratic inventions. They're evidence-based responses to real patterns of harm. Every JCI standard has a body count behind it, a trail of sentinel events, near misses, and tragedy that finally convinced the global healthcare community to take prevention seriously. The problem is, implementing these standards feels like preparing for a military inspection while simultaneously running a marathon and solving calculus problems. The Accreditation Process, a survival guide. Let's be honest, preparing for JCI accreditation is an ordeal. It typically takes 24 months of intensive preparation. Every department gets scrutinized, every policy gets rewritten, every closet gets organized like Marie Kondo is personally judging your supply room. The process goes something like this. Phase 1, denial. JCI, that's at least 2 years away. We've got time. Phase 2, panic. Wait, the survey is in 6 months. Why does nothing have a label? Who organized these medication carts? Sharon, did you throw away the crash cart checklist? Phase 3, hyperfocus. Everyone becomes obsessed with standards. Conversations devolve into debates about whether a document needs 3 signatures or 4. People dream in acronyms. The infection control nurse becomes the most powerful person in the hospital. Phase 4, the mock survey. A practice run where consultants pretend to be JCI auditors. This inevitably reveals that 60% of your policies exist only in theory. Nobody knows where the emergency generator actually is, and the medical director has been signing off on things he's never read. Phase 5. The actual survey. 3 days of pure adrenaline. Auditors roam the hospital like raptors hunting for non-compliance. Staff members smile politely while internally screaming. Someone definitely cries in a supply closet. Phase 6. The wait after the survey. You wait for the report. This period is marked by anxiety, second-guessing, and frantic debates about whether that one question about medication storage was answered correctly. Phase 7. The outcome. If you pass, celebration. The Gold Seal is displayed prominently. Marketing materials are updated. Staff members exhale for the first time in months. If you don't pass, devastation, followed by immediate preparation for the next attempt. But here's what nobody tells you during the panic. Hospitals that achieve JCI accreditation genuinely improve. Studies consistently show that JCI accredited hospitals have lower infection rates, fewer medication errors, better surgical outcomes, improved patient satisfaction, more engaged staff eventually after the PTSD fades. The process is painful, but it forces systemic improvements that actually save lives. JCI today, the global footprint. As of 2025, JCI has accredited over 1,000 organisations in more than 100 countries, from massive academic medical centres to specialised clinics, from American military hospitals overseas to luxury medical tourism destinations. The Gold Seal has become a global benchmark. Some fun facts. Medical tourism boom countries like Thailand, India, Turkey, and the UAE have heavily invested in JCI accreditation to attract international patients. It's worked. The global medical tourism market is valued at over $100 billion. Different standards, same goals. While JCI's core standards are universal, they're adapted for different facility types: hospitals, ambulatory care, clinical laboratories, long-term care, and even medical transport organisations. Because yes, even your air ambulance can be JCI certified. Continuous improvement. JCI doesn't just certify and disappear. Accreditation lasts 3 years, after which hospitals must be resurveyed. There are also unannounced surveys to keep everyone honest and perpetually anxious. The digital revolution. JCI has evolved with technology, now addressing electronic health records, cybersecurity, telemedicine, and AI integration in healthcare. The standards aren't stuck in 1998, they grow with the industry. Pandemic lessons. COVID-19 stress-tested every healthcare system globally. JCI accredited facilities generally handled the crisis better due to existing infection control infrastructure, crisis communication protocols, and systematic quality improvement culture. Turns out, having disaster preparedness plans that aren't just theoretical documents actually helps during disasters. Who knew? Why it actually matters without the corporate BS. Okay, let's cut through the noise. Memoir. Is JCI perfect? No. Does the accreditation process sometimes feel like performative compliance theatre? Absolutely. Are there hospitals that game the system, maintaining perfect documentation while cutting corners in actual care? Unfortunately, yes. But here's the truth that gets lost in the cynicism. JCI standards work. When followed genuinely, not just during survey week, these protocols create systems that catch errors before they reach patients. They build cultures where safety concerns can be raised without fear. They force hospitals to treat quality improvement as an ongoing discipline, not an afterthought. Think about it this way. Every standard is someone's tragedy prevented. That medication double check that feels redundant? It's there because a nurse once gave insulin instead of insulin-like medication, and a patient died. That surgical timeout that feels repetitive? It's there because a surgeon once operated on the wrong limb and destroyed someone's life. That hand hygiene obsession that feels excessive? It's there because countless patients have contracted fatal infections from healthcare workers who didn't wash properly. JCI didn't invent these problems. They systemized the solutions. The human element. What Codman would say. Remember Dr. Codman, our stubborn pioneer from 1910? If he could see JCI today, I think he'd have mixed feelings. On one hand, he'd probably be thrilled that his end result system, tracking outcomes, learning from failures, continuously improving, has become embedded in global healthcare standards. The principle he fought for, that hospitals should be accountable for patient results, is now enshrined in accreditation criteria worldwide. On the other hand, he'd probably take one look at the 300 plus measurable elements in the JCI Standards Manual and say, I just wanted people to follow up on their patients. How did we get here? Fair point, Ernest. But the complexity reflects reality. Modern healthcare is staggeringly intricate. A routine surgery involves dozens of people, hundreds of steps, and thousands of potential points of failure. The checklist-heavy, documentation-intense approach that drives healthcare workers crazy exists because healthcare is inherently dangerous, and systematic rigor is the only proven way to make it safer. Codman's core insight remains true. If you don't measure outcomes and learn from failures, you can't improve. JCI is essentially Codman's vision, scaled to global complexity and wrapped in enough bureaucracy to make him roll in his grave, but fundamentally serving the same purpose. The closing. Why we do this. So here we are, back where we started. You, coffee in hand, staring down another JCI requirement and wondering if this is all worth it. Let me tell you a story. A few years ago, a hospital in Southeast Asia was preparing for JCI accreditation. During a mock survey, an auditor asked to see the emergency crash cart checklist. The nurse couldn't find it. Classic JCI nightmare scenario. But here's the twist. 6 months later, during an actual cardiac arrest, that same nurse grabbed the crash cart and immediately noticed something was wrong. Because they'd spent months drilling the checklist into their memory for JCI, they instantly recognized that the defibrillator pads were missing. Someone had borrowed them for training and forgotten to return them. If that nurse had grabbed the cart during the code and found it incomplete, those critical seconds of delay could have cost the patient their life. Instead, they caught it immediately, grabbed backup pads from another cart, and the patient survived. That's why we do this. Not for the gold seal on the wall, though it's nice for marketing. Not to impress auditors, though passing feels amazing. We do this because every checklist, every double check, every tedious documentation requirement exists to close a gap where patients can slip through and die. The next time you're frantically preparing for a JCI survey, remember, this isn't about bureaucracy. It's about the patient who will survive because you caught the error. The infection that won't happen because you washed your hands. The surgical mistake that won't occur because you did the timeout. JCI didn't start as a monster designed to ruin your day. It started with one doctor who gave a damn about whether his patients lived. And yeah, it evolved into a complex, sometimes frustrating, occasionally absurd system. But at its core, it's still asking Codman's simple question. Did our patient get better? Everything else, the policies, the audits, the checklists, the panic, the gold seal, is just our collective attempt to answer yes as often as humanly possible. So the next time someone shouts, "The auditors are coming," take a breath. You've got this. And remember, behind all the paperwork and stress, there's a patient going home to their family because you cared enough to get it right. That's the real gold seal. Now go check that crash cart.